The present discussion is on kidney. First, we'll be looking at some of the embryological aspect related to kidney, and then the histology, and finally the gross anatomy. Our focus remains upon the PG entrance here and the type of questions which are coming. We should be able to handle those with the confidence and comfort. So let us begin with the embryology section here. First, we'll be taking a transverse section of the developing embryo, and there we can show the 3 germ layers as well after gastrulation. The middle layer is called as the mesoderm. So here is the mesoderm, and on the dorsum we'll have the ectoderm, whereas on the ventral side we'll have the endoderm. Endoderm is the one which is going to line the gut tube, whereas the kidney system or genitourinary system develops chiefly from the mesoderm. Now this mesoderm has one axial mesoderm, which is also called as the notochord. So here is the axial mesoderm or the notochord, and then we can mention para-axial mesoderm as well. So here we got the para-axial mesoderm, and then you can also mention the lateral plate mesoderm on the lateral side. So here is the lateral plate mesoderm. You can show it on either side, maybe right side or left side. And once you have shown the lateral plate mesoderm as well, then we are going to focus upon our chief point of discussion, which is the intermediate mesoderm. So between the lateral plate mesoderm and paraxial mesoderm, you have got intermediate mesoderm, and this intermediate mesoderm is the one which is going to give us the genitourinary system. The kidney system starts developing here. So this is the intermediate mesoderm, and it is going to form major portion of genitourinary system. And when we are talking about this intermediate mesoderm, there will be some ridges formed and some ducts are formed. And what do you call them as? Genitourinary ridges. And what are the ducts called as? Before you start talking about the ducts, you mention what the ridges are supposed to do. They'll form the kidneys, testes, and the ovaries. So as they are forming kidneys, testes, and the ovaries, they need some ducts, and those ducts are called as the Mullerian duct and the Wolffian duct. So here we are going to have the Mullerian duct, and then we also have the Wolffian duct. Now, since the males are having a Mullerian inhibiting substance, the Mullerian duct is going to be inhibited in the males. It works basically for the female reproductive system. But as you talk about the male, in the male we'll have the Wolffian duct forming the reproductive system. Now, these are the basics, and we have learned that all of that is coming from the intermediate mesoderm. But then there is a role of endoderm also in the developing genitourinary system. The terminal part of the gut tube is also going to help us. And how is that? We need to find out. Now, this is the front view of the developing embryo, and you will see this diagram is talking about genitourinary system. Major portion of genitourinary system develop from the mesoderm, but terminally there will be some contribution from the endoderm also. It is the terminal part of the gut tube, that is the hindgut. There is a cloaca region, and in the cloaca region forms urogenital sinus, and this urogenital sinus, which is in the cloaca region, in the terminal part of the gut tube, is going to give us several structures. You need to remember 3 of them. Number 1, urinary bladder, and number 2, the urethra, and number 3, the terminal portion of the vagina. So we'll be talking about the 3, once again lined by endodermal epithelium. But then our chief focus should remain upon the mesoderm, because genitourinary system is basically from mesoderm, intermediate mesoderm. And it is the intermediate mesoderm which is going to form the 3 things pronephros, mesonephros, and the metanephros. Though in the humans, the pronephros and mesonephros are going to disappear, and it is the metanephros which is going to form the kidneys as such. But kidneys do not form as such until you have stimulated them. So how do I stimulate the metanephros so that it can form the kidneys? See, the pronephros is degenerating. Even the mesonephros stays for some time during development but disappears, leaving behind a duct which is called as Mesonephros Duct or Mesonephric Duct. And this Mesonephric Duct, one on each side, will be opening at the posterior wall of urogenital sinus, which we already have mentioned was actually coming from the endoderm of the gut tube. Now, this Mesonephric Duct, one on each side, which came from the Mesonephros region, is giving us a bud which is called ureteric bud. Let us show the ureteric bud here. And this ureteric bud is the one which is needed to penetrate the existing metanephros and to convert it into what is called as metanephric blastema. And that metanephric blastema is going to form the kidneys later. Let us discuss this once again, and there we can also talk about the trigone of urinary bladder. You will notice that though the urinary bladder is from the endoderm, but minus the trigone, because the trigone on the posterior wall of the urinary bladder is actually from the mesoderm. It is formed by the absorption of the tip of the mesonephric duct into the posterior wall of urogenital sinus. Hence, maybe urinary bladder is entirely endodermal, but except the posterior trigone, which is in fact mesoderm, from intermediate mesoderm. Now we need to look at these structures from a lateral view as well. So, as we mentioned, it is going to be a lateral view of the developing baby, and there was one anterior gut tube which is endodermal in origin, and there is one posterior mesodermal structure, intermediate mesoderm, which is going to help us in formation of genitourinary system. And especially we are focusing upon the urinary system. There were actually three things: the pronephros, the mesonephros, and the metanephros, which are formed in the intermediate mesoderm. But then the pronephros disappears, even mesonephros disappears, only metanephros is existing so that it could form the kidney. But kidneys do not develop by themselves. They need some stimulation that is provided by the mesonephros, leaving behind a duct called mesonephric duct. So, mesonephros is giving us mesonephric duct, which you can show. It is here. This mesonephric duct is going to be one on each side, right side and left side, and opening into the posterior wall of the urogenital sinus. This urogenital sinus is actually developing in the cloaca region of the terminal hind gut here. Let us show the hind gut portion here. This is the hind gut, and the terminal part of hind gut, there is the cloaca region, and there develops the urogenital sinus. Now this urogenital sinus is giving us several derivatives, but then our focus remains upon three things: the urinary bladder, the urethra, and the terminal parts of the vagina. They are all lined by endoderm of the urogenital sinus. And what we are mentioning is about the mesonephric duct opening at the posterior wall of urogenital sinus is going to be mesodermal. Let us magnify this area a little bit now. And as you do so, you will notice one ureteric bud, which is coming from the mesonephric duct, and It is important because it is the ureteric bud which is going to penetrate the metanephros and convert metanephros into metanephric blastema. And then it is the metanephric blastema which is later going to form the kidneys. Now remember, if the ureteric bud is unable to penetrate the metanephros, there will be no kidney renal agenesis, or it may happen that there is a problem with the penetration of ureteric bud into the metanephros, and that can result in polycystic kidneys. Also, a failure of the communication of the ureteric bud derivatives with the metanephros kidney components. Polycystic kidneys can also happen here. So let us draw this diagram ourselves now. Anteriorly is the gut tube, endodermal gut tube. Posteriorly is the intermediate mesoderm. So this is again the side view, lateral view of the developing baby, and we are telling anteriorly there will be the endodermal gut tube, and posteriorly there will be the mesoderm, intermediate mesoderm. It is the intermediate mesoderm which will form the kidney system, whereas the anterior endoderm is now going to form the gut tube. So let us first draw the gut tube, and the gut tube will have three parts basically, which you can mention as the foregut here, the midgut, and then the hindgut here, all lined by endoderm. Now, in the hindgut region, terminally you have a cloaca region, and in the cloaca region develops one septum, which is called urorectal septum. So, in the cloaca region of the hindgut, we have urorectal septum. It is called so because in front of urorectal septum is developing urogenital sinus, and posteriorly develops the rectum. So here, posteriorly you have rectum, anteriorly you have urogenital sinus. And this urogenital sinus, you can magnify a little bit here, is the one which will give us some derivatives, three of them which you need to remember. And they are the urinary bladder and the urethra. And there is the terminal part of the vagina as well. Now, may it be urinary bladder, urethra, or terminal part of vagina, they're all lined by endoderm of the urogenital sinus. But be careful. When it comes to the trigone of urinary bladder and posterior wall of the proximal urethra, there we find some mesoderm coming up. Now, how come this mesoderm has come here? And what is this called as? This is the trigone of the urinary bladder on the posterior wall of urinary bladder, which will be mesodermal. But how come this mesoderm has come on the posterior wall of the endoderm? This is what we will be discussing now. So, as we zoom out here, we have known there is some mesoderm on the posterior side, the intermediate mesoderm, which is going to form the pronephros, mesonephros, and the metanephros. And this pronephros or the mesonephros, they are going to disappear. Only metanephros is persisting in the humans. And this metanephros is the one which is going to form the kidney system. But it cannot form the kidney system just like that. You need some stimulation. And as you mentioned, pronephros is going off. Mesonephros is going on. As the mesonephros was disappearing, it will leave behind one duct on each side, right side, left side, called Mesonephros Duct. And this Mesonephros Duct is going to open into posterior wall of the urogenital sinus, as you can show here in the diagram. So there is one Mesonephric Duct, one on each side. Because you're looking from the lateral view, this is only one of them visible. And this mesonephric duct is important because it will give us a bud which is called ureteric bud now. And that ureteric bud is important because it is going to penetrate the metanephros. And as the ureteric bud is going to penetrate the metanephros, now the metanephros will be stimulated to form metanephric blastema, and it is the metanephric blastema which will form the kidney, the true kidney, the excretory portion of the kidney, basically the nephrons. So here develop the nephrons. The nephrons will be forming the urine, and that urine will be collected by collecting system. Kidney has two parts. One is excretory system formed by nephron, and one is collecting system. The collecting system is contributed by ureteric bud. It is the ureteric bud which will be forming some derivatives. You have to remember 5 derivatives at least, and those 5 derivatives will be in the collecting system embryologically, and they'll be collecting the urine which is already found by nephron system. Now, before we start discussing upon that, you see this tip of the mesonephric duct is now being absorbed into posterior wall of the urogenital sinus, and it is this terminal portion which is going to form the trigone of urinary bladder and posterior wall of the prostatic urethra proximally. So this all becomes mesoderm because it is coming from the tip of the mesonephric duct from the intermediate mesoderm. And later, this mesonephric duct will be also called as the Wolffian duct, this proximal portion which is left now, and this Wolffian duct is going to form male reproductive system. So mesonephric duct in a female is important for inducing the formation of the renal system, kidney system, and also forming the trigone of urinary bladder. After that, the mesonephric duct in a female is vestigial because Wolffian duct works only for male reproductive system. Females will have the Mullerian duct working for reproductive tubes. So, as we mentioned, kidney has 2 parts. One is excretory portion and one is the collecting portion. The excretory portion comes from the metanephric blastema, which will form the components of nephrons. You can see that here. Plus, if you are talking about the collecting system, then it will come from the ureteric bud, and ureteric bud, at least 5 derivatives we need to memorize. But first you have to look at the true kidney on the metanephric blastema forming the nephrons here. Now this metanephric blastema, the intermediate mesoderm, is going to give us renal glomerulus, the capillary system which will give us ultrafiltrate called as urine, and that urine will be poured into the Bowman's capsule, then PCT, loop of Henle DCT, and then it will be coming to the connecting tubule. So this all comes under metanephric blastema. And once the urine is formed, then you need to collect it. Then you start discussing the collecting system, at least 5 derivatives of ureteric bud. So what are the 5 derivatives of ureteric bud? You see, the ureteric bud is going to form ureter. And this is number 1. Number 2, the pelvis, renal pelvis. So number 1 is the ureter. Number 2 is the renal pelvis. Number 3 is the major calyx. Here, as you see, number 4 is minor calyx. Number 5 is collecting ducts. So this is 3, 4, and 5. As you can see in the diagram, the major calyx, then the minor calyx, and finally the collecting ducts. The 5 derivatives of ureteric bud. You can revise them again. Number 1 is the ureter, ureteric bud giving ureter. Number 2, renal pelvis. Number 3 is the major calyx. Number 4, minor calyx. And number 5, the collecting ducts. Why I'm stressing upon here is because a question comes, they'll ask you about connecting tubule. Be careful, there is a connecting tubule and there's a collecting tubule. Collecting means it will be under the collecting system, the ureteric bud derivative. But if you say connecting tubule, then it belongs to the nephron, and it is the one which is connecting the nephron with the collecting system. Let me draw a diagram, then it will become more clear for you. But remember, connecting tubule is a derivative of metanephric blastema, whereas the collecting tubule is a component of ureteric bud embryologically. So as we continue, let us move on to histology from embryology and merge it with gross anatomy as well. In fact, everything is connected and should be discussed in a coordinated way. So here we are looking at the kidney. As we suggested, kidney will have two parts embryologically, excretory portion and the collecting portion. But then here our focus will remain on the excretory portion, the nephron system, and we can discuss some histology part as well. Now kidney has got one outer region, the renal cortex, and then there is the deeper portion, medulla, and this medulla is multiple pyramid shaped structure which you can see here, medullary pyramids. Now this renal cortex, which is in the periphery, keep dipping down, getting sandwiched between the medullary pyramids here. And similarly, we can find that even the medullary pyramids, they keep sending some medullary rays towards the periphery, and which will be moving into the peripheral cortex. So we'll be discussing the details in a short while, but at the moment, let us just magnify a portion of the cortex and medulla here to discuss some of the histology features. And we are zooming out now. You need to remember that outer portion is the cortex here, and then the deeper portion is the medulla in this diagram. So this area is the cortex, the peripheral portion, and if you are going deeper, then this portion is the medullary portion. Why I'm telling you this is because some component of the nephron are in the cortex and the others are in the medulla. Now, the nephron, the structural and functional unit of kidney, it begins with the glomerulus. There are some blood vessels and they are sending us the glomerulus. You can magnify this area a little bit now and mention about this capillary plexus called as the glomerulus, and that is where there will be one ultrafiltrate of blood coming up, which will be poured into the Bowman's capsule here as urine. So urine is ultrafiltrate of blood. Now this Bowman's capsule has a double layer. There is an outer parietal layer, and then you will find there is one inner visceral layer. But both the layers are simple squamous epithelium, as is the lining of the glomerulus, the capillaries as well. The endothelium is also simple squamous epithelium. Now you can see the flat cells of the Bowman's capsule, simple squamous epithelium. Maybe it is the parietal or peripheral layer, or maybe it is the inner or the visceral layer of Bowman capsule. It is simple squamous epithelium. And as you zoom it a little bit, you can find there will be some podocytes also in the visceral layer of the Bowman's capsule. And these podocytes, they have multiple foot processes, and they are basically sitting on the basement membrane of both the Bowman's capsule and the capillary endothelium also. Now in the kidneys, the capillary endothelium is fenestrated, and that is how you can actually filter the blood towards the Bowman's capsule. And that ultrafilter of blood, which is collected now by the Bowman's capsule, will be moving into the proximal convoluted tubule, which is shown here. Now, let us zoom out a little bit here, and you can see this PCT is basically in the cortex. It's a proximal convoluted tubule, which will then become the loop of Henle, which is lying in the medulla, the deeper portion. And when it comes back again, there'll be a distal convoluted tubule, which is on the outer cortex. So the point is, may it be the glomerulus, Bowman's capsule, PCT or DCT, they are in the periphery, the cortex region. It is the loop of Henle, which goes into the medulla, and also the collecting ducts. But remember, these collecting ducts actually have begun already in the cortex. So from the cortex, they move into the medulla. And though chiefly they are in the medulla, but they are also projecting into the cortex. So this urine has been put now into the collecting duct, and this collecting duct will carry it towards the remaining portion of the collecting system. That is basically the minor calyx, major calyx, etc. Now coming to the epithelial lining. If you are talking about the PCT or DCT, both of these have a simple cuboidal epithelium with some microvilli. But be careful, PCT is doing more of absorption and hence it'll have a lot of microvilli. It's a simple cuboidal epithelium with a lot of microvilli forming the brush border. Whereas if you are talking about the DCT, though it is also simple cuboidal epithelium with the microvilli, but microvilli are very few in number, so there is no brush border in the DCT. Though absorption keep happening here, but it is less as compared with the PCT. And if you compare them here, the PCT will be showing a lot of microvilli towards the lumen, as you can zoom a little bit here, but the DCT, though the cells are cuboidal epithelium only, microvilli are almost missing in the DCT. There is no brush border which you find in the PCT. And what about the loop of Henle? As you talk about the loop of Henle, you will see you'll be having a simple squamous epithelium. Here, the flat epithelium. But then loop of Henle will have mostly a thin segment, but there is a small portion which is thick segment also. Now, thin limb of loop of Henle is simple squamous, but if somebody specifically is talking about the thick limb, then you have to be careful because there the epithelium changes into low cuboidal epithelium. So this is what we need to mention in the diagram, which we'll be drawing ourselves as well. That most of the loop of Henle is thin segment, so simple squamous, but a short portion is a thick portion of the loop of Henle, and there we can have low cuboidal epithelium. This is all a discussion to take care of the type of questions which keep appearing in the PG entrance exam. And then you can also talk about the epithelium of the collecting duct. The epithelium of the collecting duct is simple columnar epithelium. Actually, it begins as the cuboidal epithelium and gradually becoming columnar. But if somebody asking, what is the epithelium of collecting duct? You must say it is simple columnar epithelium having two types of cells. One is the principal cell, one is intercalated. And the intercalated cell in the collecting duct has microvilli, which you can see here. Under the antidiuretic hormone, it will be involved in water absorption, and later it will be continuing into the renal papilla and forming the papillary duct. May it be the papillary duct or may it be the collecting duct, the lining epithelium is simple columnar epithelium. So let us draw a diagram for nephron now. We see nephron is having a Bowman's capsule, a PCT and loop of Henle, DCT and a connecting tubule. Here you can mark it as the Bowman's capsule and then you can mention as the proximal convoluted tubule, whereas this is the loop of Henle. And then we have got the DCT here, distal convoluted tubule, which will then continue as the connecting tubule. As I said, the connecting tubule is a part of the nephron, which will be connecting the excretory portion with the collecting portion. Embryologically, it would have come from the metanephric blastema, and metanephric blastema will also form this tuft of capillaries called as the glomerulus. And this glomerulus is lined by endothelium, and that endothelium is simple squamous epithelium, and it is fenestrated, as we said, because we need ultrafiltrate of blood forming here called as the urine. And this urine will be then collected by the Bowman's capsule. Now this Bowman's capsule or the loop of Henle. Both of them have the same epithelium, which is simple squamous epithelium. As we said, is same for the endothelium. So may it be glomerulus or the Bowman's capsule or the loop of Henle, they have simple squamous epithelium. Whereas when you talk about PCT proximal convoluted tubule or DCT distal convoluted tubule, then they have simple cuboidal epithelium. Now, when you say they have got this simple cuboidal epithelium, there is one difference, and that is the distribution of the microvilli. You see, the proximal convoluted tubule is involved in more absorption. It is absorbing water, sodium, amino acids, glucose, etc. There is a sodium, potassium, ATPase pump also. So most of the absorption keep occurring in the PCT has more of microvilli. So here you see it is a central spherical nucleus, but a lot of microvilli. PCT is a simple cuboidal epithelium with brush border due to microvilli. Now, even the DCT has the same appearance, that it is a cuboidal cell with central spherical nucleus, but the number of microvilli are very few. So few that they do not qualify as brush border. The brush border is present only in the PCT, not the DCT. And DCT is under the hormone aldosterone, renin, angiotensin, aldosterone system. And it is also doing the absorption, but less as compared with the PCT. And remember, may it be glomerulus, Bowman's capsule, PCT or DCT, they are in the outer portion, the renal cortex, whereas the loop of Henle goes into the renal medulla deeply. And this loop of Henle, most of it is thin loop of Henle, which is simple squamous epithelium. But if somebody specifies the thick ascending limb of the loop of Henle, then you have to mention there is low cuboidal epithelium here. Low cuboidal epithelium there. Now, this was the excretory portion. What about the collecting portion of the kidney? So the urine is already formed and we need to collect it now. It begins with the collecting ducts. And where is this collecting duct putting the urine then into minor calyx? And from the minor calyx it will go to the major calyx, and then it will go to the renal pelvis, and then it will move into the ureter. And if you remember, we have discussed the 5 derivative of the ureteric bud embryologically. Number 1, ureter. Number 2, renal pelvis. Number 3, major calyx. Number 4, minor calyx. Number 5, the collecting ducts. These are the 5 derivatives of the ureteric bud. And to tell you, they are all lined by transitional epithelium. But be careful when you say the transitional epithelium or the urothelium, it begins only at the tip of the collecting ducts. If it begins only at the tip of collecting ducts, then what is the major lining of the collecting duct? We already mentioned collecting ducts will be lined by the simple columnar epithelium with the principal cell and the intercalated cell with microvilli. It was simple columnar epithelium. Only the tip of the collecting duct will have transitional epithelium, and then the transitional epithelium lines the minor calyx, the major calyx, the renal pelvis, and ureter. It is also present in the urinary bladder, proximal urethra. Till the proximal half of prostatic urethra, you'll find it is transitional epithelium. After that, the epithelium will change. Now let us have an idea over the location and the relations of the kidneys. As you will see, kidneys are retroperitoneal organs and are lying in the lumbar region. But not only they lie in the lumbar region, there is actually overlapping of 4 regions. First of all, let us mark the kidneys here. This is the right kidney, and we can mark the hilum of right kidney here. This is the hilum of the left kidney. And as you can notice one thing here, the right kidney is comparatively at a lower level than the left kidney. Actually, what happens is during development, intermediate mesoderm is going to form the kidneys in the pelvis region, and later the kidneys will ascend into the abdomen. Now, since on the right side we have the right lobe of liver, it is not allowing the right kidney to ascend too high compared with the left kidney. The left kidney ascends a bit higher as there is a stomach lying in this region. You can see one more thing here. L1 vertebra, the lower border, is a transpyloric plane. That is where we see the pylorus of the stomach. And this transpyloric plane is going to cross hilum of each kidney. You can notice it is touching the hilum of right kidney at the upper level and left kidney at a lower level. But the transpyloric plane definitely passes through hilum of each kidney. And that is where the abdominal aorta will be giving renal arteries. Of course, the left renal artery will be going higher as compared with the right renal artery. Now, what about the quadrants these kidneys are present in? First, let us mark the boundaries here, and you will notice there are two vertical planes, there are two horizontal planes, and then we find the kidneys are actually at the junction of four quadrants. As you see, kidneys are basically lying in the lumbar region. This is the right kidney, the left kidney, but then they are also encroaching under the costal margin. So this is the right hypochondrium under the right costal margin, and this is the left hypochondrium under the left costal margin. Then the kidneys are also encroaching into the epigastrium. This is the epigastrium region, and then plus you can see they are also encroaching in the umbilical region. So basically it is the junction of the umbilical region, epigastrium, hypochondrium, and the lumbar quadrant as well. Now let us have a brief idea about the structure of the kidney, because we want to see a dissected specimen of the kidney. And for that purpose, we already have discussed some of the details. So it will be kind of a revision that the kidneys have an outer cortex, and then there will be a deeper medulla as well. And in fact, the renal medulla is in the shape of pyramids. This is one renal medullary pyramid. This is another renal medullary pyramid. There is one more here. And you can see the medullary region here as well. This is one of the medullary pyramid. And as you can mark it here, this is the renal medulla in the deeper level, whereas this is the renal cortex in the superficial level. And as we mentioned earlier, the nephron, the uriniferous tubule, having the glomerulus, Bowman's capsule, PCT, DCT, they will be on the outer side, the renal cortex region, whereas when it comes to the loop of Henle, it will be dipping down into the renal medullary region. In the medulla, you will also have the collecting ducts, but the collecting ducts actually begin in the cortex region. So here, the collecting ducts are present chiefly in the medulla, but they also project into the cortex. And when these collecting ducts are projecting into the cortex, they will produce what is called as the medullary rays. You will notice there are several medullary rays which are coming from the medullary pyramids, encroaching upon the cortex, and they are basically marking the collecting ducts in the cortex. So medulla encroaches into the cortex. Similarly, we will find that even the cortex is getting sandwiched between the medullary pyramids, and these intermittent cortical projections into medulla are called as the renal columns of Bertini. Renal columns of Bertini. Now, outer is the cortex, inner is the medulla, and still deeper is the renal sinus. And in the renal sinus, you will see the tip of the medulla, the urine is being sent into the renal papilla. And from the renal papilla, the urine will be moving into the minor calyx. And from the minor calyx in the renal sinus, the urine will be taken towards the major calyx and towards the renal pelvis and then towards the ureter and then the urinary bladder and urethra to the exterior of the body. And also remember what we have shown here is a small portion of the kidney which is including part of the cortex, medulla and the renal sinus, and that is called as the lobe of the kidney, partly cortex, medulla and the renal sinus. So kidney will have multiple such lobes as such. It's a lobulated organ embryologically. And now let us have a look over the dissected specimen of kidney. So once again we can mark the outer cortex here, and then we can mention the deeper medulla having the medullary pyramid. So this is one medullary pyramid here, another medullary pyramid here, and then you can mention, if we are including one medullary pyramid and the cortex related to it, and also the renal sinus where you have the renal papilla putting the urine into the minor calyx, then this is considered as one lobe of the kidney. Plus you can show the renal columns of Bertini as well, which are sandwiched between the renal medulla. Then you can mention the urine which is formed in the uriniferous tubule will be received by the minor calyx, and from the minor calyx it will go to the major calyx, and from the major calyx it will be reaching the renal pelvis and then continuing as the ureter. So this is the ureter carrying the urine towards the urinary bladder and urethra to the exterior. And as such, kidney is a lobulated organ embryologically. Now, when we talk about the relations of the kidneys, it is observed kidneys are the most posterior organs here. This is the right kidney and you can see the left kidney as well. And they are retroperitoneal behind the peritoneum, and behind all the viscera there is no viscera behind the kidneys. So whichever viscera are related to kidneys, they will be all in anterior relation. For example, you have removed a large organ from here, the liver. The liver relates with the right kidney, and then you have removed the stomach from here. The fundus of stomach relates with the left kidney. So left kidney will have a gastric area and the right kidney will have a hepatic area anteriorly. And there will be ascending colon, transverse colon, descending colon related to the kidneys. Of course, the right colic flexure with the right kidney, left colic flexure with the left kidney. Plus, there will be the pancreas. So let us put them back, those viscera, and find out all the details. So here first, let us mark the various viscera in front of the kidneys and then remove them and have their impression on the anterior aspect of both kidneys. Let me first mark the outline of the kidneys. This is the right kidney here, which we are giving the outline. And then we can also mark the left kidney. And once we have given the outline of the kidneys, then we can talk about the structures which are lying anterior to them. Like we said, we have removed a large organ from here, the liver, and it is the right lobe of the liver which relates to the right kidney anteriorly, the hepatic area. Whereas the left kidney is related with the stomach, fundus of stomach, gastric area there. Plus we mention that in addition to this gastric area for the stomach in front of the left kidney and the hepatic area for the anterior surface of right kidney, we have got the colon area as well. As you can see, this is the ascending colon here, the right colic flexure, the hepatic flexure of colon, and then we can see the transverse colon will be passing anterior to the pancreas. In fact, there is a transverse mesocolon attaching to the anterior border of the pancreas, and then there will be a left colic flexure or splenic flexure of colon. So here is the left colic flexure or the splenic colic flexure of colon. As you can see, the colic flexure relates with the spleen anteriorly and also the left kidney anteriorly. You can mark them here, the right colic flexure on the kidney shown here, and then you can also show it on the anterior aspect of the left kidney, the left colic flexure and the descending colon area on the anterior aspect of the left kidney. And then you can mention in front of the right kidney, we have second part of the duodenum. See, this is duodenum 1, duodenum 2, duodenum 3, and duodenum 4. So it is the second part of the duodenum, which is lying anterior to the right kidney, as you can mark here, as well as you can show it in this diagram here. The second part of the duodenum in front of the right kidney and also hilum of the right kidney. In fact, it is in front of the right ureter also. The second part of the duodenum. And then you can mention the adrenal gland as well, lying anterior to the right kidney. 4 structures you can mention lying anterior to the right kidney, and they are: number 1, right adrenal gland, and number 2, the liver, and number 3, it is the second part of duodenum, and number 4, the right colic flexure. So, what are the anterior relations of the left kidney then? See, if you have adrenal gland related to anterior aspect of the right kidney, it is also the same way for the left kidney. So, this is the left adrenal gland, which is lying anterior to the left kidney. And what are the other structures lying anterior to the left kidney? We already have mentioned it is the adrenal gland, the gastric area, the colic area, and then you have to mention the pancreas. But remember, when you are talking about the pancreas, it lies in the C loop of the duodenum, the head of the pancreas. Then you have the body of pancreas and then the tail of pancreas. As such, the pancreas has no relation with the right kidney. There is no marking on the right kidney, but then definitely there is a marking of the pancreas on the left kidney as it passes anterior to it. And you can say the body of the pancreas is lying anterior to the left kidney here. So as you mark the body of the pancreas lying anterior to the left kidney, where is the tail of the pancreas? Actually, tail of the pancreas is not related to the kidney. Tail of the pancreas relates with the hilum of the spleen. As you can see, the tail of the pancreas will be relating to the spleen here. Now understand that spleen itself has anterior location to the left kidney, and this is the area of the spleen which will be putting marking over the kidney. It will be becoming more clear when we draw our own diagram. But understand that tail of the pancreas is the most anterior structure. Behind that will be the spleen, and behind the spleen will be the left kidney. Anterior to posterior, you have the tail of pancreas, then you have the spleen, and then you have the left kidney. Or you can say the left kidney is separated from the tail of pancreas by the spleen. Spleen is sandwiched between the tail of pancreas anterior and the left kidney posterior. That becomes more evident in the diagram which we are going to draw now. So let us begin with the 4 parts of duodenum here. The C loop of duodenum, part 1, part 2, part 3, and part 4 of the duodenum. And in the C loop of the duodenum, you have the head of the pancreas. So here is the head of the pancreas, and then it will be obliquely placed body, and then you can mention the tail of pancreas as well. But then remember, the tail of pancreas relates with the hilum of the spleen. So let us draw the spleen here and mention the tail of pancreas going to the hilum of the spleen. As such, it will not be related to the kidney lying posterior. Then let us draw the outline of the left kidney, the most posterior structure here. So this is going to be the left kidney here. And as we mentioned, the left kidney will be relating to the body of the pancreas and not the tail of the pancreas, because tail of the pancreas relates with the hilum of the spleen. So which is the most anterior structure? The tail of the pancreas. And what is behind that? The spleen. Then what will be behind the spleen? Behind the spleen will be the kidney. So the most anterior structure is the tail of pancreas, which do not relate with the kidney, and sandwich in between will be the spleen, and the most posterior structure will be the left kidney. So left kidney has no relation with the tail of pancreas. It is related only with the body of pancreas. Then what about the relations of the right kidney? Let us draw the right kidney here and mention it is the second part of the duodenum, which relates with the right kidney anteriorly. And not only the second part of the duodenum lies anterior to the right kidney, but also there will be a hepatic area, as we have removed the liver from here, and liver relates to right kidney anteriorly. Now, if this is the hepatic area, then this must be the adrenal area, the suprarenal gland. Yes, that is the right adrenal gland, which is lying anterior to the right kidney, and this is going to be the left adrenal gland lying anterior to the left kidney. And then you can mention this triangular area, which is for the fundus of the stomach. So here lies the fundus of the stomach. Actually, we have removed the stomach, then only we can see the kidneys and pancreas. Until otherwise you remove the stomach, you cannot see the kidneys or pancreas. They are lying in the stomach bed, behind the stomach. And then you can mention about the colon as well. You will notice there is a ascending colon here, which is becoming the right colic flexure and putting an impression on the anterior aspect of the right kidney. So this is the right colic flexure. And then the colon is attaching to anterior border of pancreas. The transverse mesocolon will be here, attaching to anterior border of pancreas. And then it will come down as the descending colon. There will be a splenic flexure of colon here. And that splenic flexure of colon will be related to the anterior aspect of the spleen and also the anterior aspect of the left kidney. So this is the anterior relation of the left kidney to the splenic flexure of colon, the left colic flexure, which is also called as the splenic flexure of the colon. So what are the anterior relations of the left kidney again? It is the left adrenal gland, the fundus of the stomach, the body of the pancreas, and the splenic flexure of colon. And what will be related here? It is few coils of jejunum in front of the left kidney and few coils of jejunum in front of the right kidney. So once that is clear, let us look at the posterior relations of kidney as well. Actually, behind the kidneys, we will have the ribs and the muscles. Now, this is the posterior view of both the kidneys. You can see the midline vertebra and the ribs here. Let me put the outline of the kidneys. So this is the left kidney, which is a bit higher as compared with the right kidney. We have mentioned earlier that during development, the right kidney could not ascend higher because of the liver present here, whereas the left kidney could ascend because stomach was located there. And that is why we find that right kidney is related only with the 12th rib, whereas the left kidney relates with 12th rib as well as the 11th rib. And both of them are related to the diaphragm, which is taking its origin from the lower ribs. So in the posterior relation of both the kidneys will be the diaphragm in the upper part, which takes origin from the lower ribs interior. But then there are three muscles related to the kidney posteriorly in the lower region. So what are the three muscles related to both the kidneys posteriorly? Most medially we find there is this psoas major muscle taking origin from the lumbar vertebra, and it will be related to the kidneys on either side. here. Then you can mention there is a quadratus lumborum muscle on the posterior abdominal wall behind the kidney, can be shown here, quadratus lumborum. And then there is one more muscle, which is actually muscle of the anterior abdominal wall, but going posteriorly and getting related to the kidneys, the transversus abdominis muscle, and that will be the lateralmost muscle here, the transversus abdominis muscle in posterior relation of the kidneys, as you can see there. And you need to remember 3 nerves as well, 3 muscles and 3 nerves in the posterior relation of both the kidneys, because when you are approaching the kidneys for operative surgeries posteriorly, then you have to be careful about those 3 nerves. We have a schematic diagram for that now. So, as we mentioned, kidneys are the most posterior viscera. There are no viscera behind the kidneys, only some rib and muscles are there. If you are talking about the ribs, it is the 12th rib, which relates with the right kidney, and it is also relating with the left kidney, but left kidney has relation with the higher rib or 11th rib as well. So left kidney relates posteriorly with 2 ribs and right kidney relates with only the 12th rib. Attaching to the ribs on the interior will be the diaphragm. So the diaphragm is relating to the posterior aspect of both the kidneys here. And in addition to this diaphragm muscle on the posterior relation of the kidneys, there are 3 muscles in addition. So which was the most medial muscle? The most medial was taking origin from lumbar vertebra, and we called it as the psoas major muscle, related to the kidneys posteriorly. Then which muscle was in the middle? The quadratus lumborum. So here is the quadratus lumborum, related to kidneys posteriorly. And then you can mention the 3rd muscle related to kidneys posteriorly. It is actually a muscle of the anterior abdominal wall, but going posteriorly to relate with the kidney in the lateral aspect, transversus abdominis muscle. So here is the transversus abdominis muscle in the posterior relation of the kidneys, not only the left kidney but also the right kidney. And once you have shown the 3 muscles posteriorly, you have to talk about the 3 nerves as well. See, this is the 12th rib, and under the 12th rib will be coming subcostal nerve. So here you can show the subcostal nerve related to the kidney posteriorly on both the sides. And along with the subcostal nerve, we also have got the iliohypogastric nerve coming from lumbar plexus on either side. And then we have got ilioinguinal nerve also related posteriorly to either of the kidneys. So hence we have seen 3 nerves related to the kidneys posteriorly. When you are approaching the kidneys, say for example you wanted to remove the kidney and do a renal transplant, in that approach, the lumbar approach, you must be careful about these nerves in posterior relation to the kidneys.